This is the first time I've ever been to this site, Homeland Defense and Security Information Analysis Center. It took me a long time to find it. I was doing a lot of different searches and narrowing the criteria, and eventually I found what I was looking for, and it ended up being on this site. It's the most in-depth description and explanation of Ebola that I've come across yet, so I thought I would share it. I'm not going to go through the whole page. It's very long, and this video is going to be long enough as it is, so I'm just going to highlight what I thought was the most important stuff, but I'll put the link, and please go check it out. Really good information. It's meant for professionals. Like, it reads clinically, so I'll words that I didn't understand, terms I didn't know what they were, I'll go over them. And obviously anything I don't go over, just, you can Google it yourself or figure it out. First off, it goes over the natural occurring viral hemorrhagic fevers, the entire class. So there's Ebola, Marburg, Lassa virus, New World viral hemorrhagic fevers, Rift Valley fever, yellow fever, and dengue hemorrhagic fever. And then it goes over the transmissions, who carries it, and so forth. All right, as it relates to Ebola, African fruit bats are considered the natural host, although monkeys also carry it. In the third line down, human-to-human transmission of Ebola virus is primarily associated with direct or indirect contact with blood and body fluids, which is obviously CDC and WHO will not tell you that. Direct or indirect. And then transmission to healthcare workers has been reported when appropriate infection control measures have not been observed. So when they're not doing it correctly, healthcare workers will catch the virus. Clinical features of Ebola HF, hemorrhagic fever, begin with a prodrome early symptom period of 2 to 21 days, which we've been told, which then steadily progresses to yield a characteristic cluster of physical symptoms and manifestations coupled with flat affect, which means you don't really show emotion on your face. It's very monotone. And sunken eyes, often referred to as mask-like or ghost-like. During the early symptom period, which is basically the incubation period, symptoms are nonspecific and can be easily misdiagnosed or overlooked by medical professionals, public health workers, and safety specialists. After the clinical disease declares itself, initial prodromic symptoms typically progress over 4 to 5 days to a general toxic presentation with more pronounced fever, severe myalgia, including pain on palpitation, which is your heart, and joint pain. Prominent gastrointestinal symptoms include diarrhea, which may include vomiting, coupled with colicky abdominal pain and profound anorexia. A papular or malcopapular rash on the upper arms, flexor surfaces on the forearms and upper leg often develop, which may progress to desquamation, shedding outer skin layers, in the same distribution as well as palms and soles of the extremities. Terrible. Just like awful symptoms. So to sum that up, after you start presenting, after the incubation period is over, within 4 to 5 days, one by one, all these things start happening. Right? Basically is what that says. All right, these are the symptoms which will first present. Okay, progressive flu-like illness can be mistaken for malaria or other non-specific viral syndrome. Chief complaints of the patient include mild fever between 100 and 102, severe headache, general myalgia, and arthralgia, which was the joint pain, particularly of the lower back, dry, sore throat, and chest pain with dry cough. All right, again, this is very clinical, but I'm just going to read it. Hemorrhagic bleeding diathesis predispositions include gastrointestinal, which is watery diarrhea with fresh blood, stool, vomiting of fresh blood. Naso or orophageal, mouth, gums, and nose, nasal, ocular, which are eyes, and genital presentations. Okay, so bleeding from everywhere, basically. Common early central nervous systems include stiff neck, common to meningitis, but with clear cerebrospinal fluid. But as the disease progresses, patients often exhibit bizarre behavior, including a tendency to leave place of care and wander in a confused state. I put out a video on that guy in a red shirt just walking around a market. Severe cases progress to death from 2 to 21 days after clinical presentation, with a peak of 9 days. And that information right there has been hard to come by. I've had trouble finding that. So death within 2 to 21 days with an average peak, I guess, of 9 days. Okay, now these are the symptoms that will come after what I just mentioned. So now we're into the hemorrhagic fever stage. So acute onset fever, severe prostrating or life-threatening illness, bleeding manifestations, at least 2 of the following: hemorrhagic or purpuric popular rash, epistasis, hermetistasis, hemophilus, blood in stool or other bleeding. No predisposing factors for bleeding diathesis. Disease presenting with similar symptom clusters include the following. You can see there's a whole list of things that Ebola resembles, unless you get the test back and depending on how sick the patient actually is. And I want you to pay attention to the 5th one down on bacterial, septicemic plague. I'm going to put out another video on that. That was basically the Black Death. And there's a lot of talk that maybe the Black Death was Ebola, and maybe this Ebola outbreak is actually septicemic plague. Like I said, this video is going to be too long to go over that. I'll do that in another video. But you can read all these things that mirror Ebola. Okay, recent field reports suggest that many patients do mount a robust humoral immune response concurrent with reduced viral load. But loss of functional integrity of the gut, particularly the lower intestine, typically results in bacterial sepsis, shock and death subsequent to bacteremia, which is bacterial infection of the blood. So what it's saying is the immune system kicks in and begins to actually reduce the virus, starts to kill the virus, but because your gut has been so compromised by the virus, your blood gets infected and you end up dying from sepsis, which is what I was talking about with that septicemia plague, right? Okay, keep going. This observation suggests that evolving clinical management strategies may require both antiviral medical countermeasures coupled with more traditional methods for managing both bacterial sepsis from intestinal flora as well as associated shock and clinical consequences. Laboratory testing to confirm the diagnosis is often complicated by challenging field conditions and lack of readily available sophisticated nucleic acid amplification-based capabilities, which is why the testing takes so long. Ebola viruses may be recovered from soft tissue effusions, semen, and interior eye fluid, especially during later stages of illness. Diagnosis is most typically performed using blood or serum samples. So again, the important takeaway, the immune system kicks in, usually, and is fighting the virus off, but the virus has so compromised your intestines that you end up dying from sepsis. And then here they talk about a 5x5 test. So for all, you need to be positive for all 10 of these to be diagnosed with Ebola. Right? If any fall short, then the test ends up coming back negative. So the clinical signs, I'll read those because the laboratory signs, those are meaningless to me. 99% of the people out there. So the 5 clinical signs: you've had contact with an infected individual, retroorbital headache, retroorbital is behind the eye, pharyngitis, swelling of the back of the mouth, myalgia, which is the pain, documented or subjective fever and or chills. So if you have those 5 things, then the testing comes back, and if those 5 test criteria are met, then you have Ebola. Okay, this hopefully will not become important for you, but it may. Supportive care is essential for patients with Ebola hemorrhagic fever and includes maintenance of fluid and electrolyte balance, active hemodynamic monitoring, mechanical ventilation, dialysis, and appropriate therapy for secondary infections. Treatment of other suspected causes of disease, such as bacterial sepsis, should not be withheld while awaiting confirmation or exclusion of the diagnosis of Ebola HF. Now, this last sentence here, anticoagulant therapies, so blood thinning therapies, aspirin, non-steroidal anti-inflammatory medications, and intramuscular injections are contraindicated. Contraindicated means don't do it. So don't give blood thinners, aspirin, non-steroidal anti-inflammatory medications, or injections. Do not do that. I'm not going to read the second paragraph. If you want to read it, pause the video and you can read it on your own. Okay, now they're going to talk about, there was an Excel Bio did a analysis, and there's an 8-point summary. I'm going to go over a couple of them. So 1, 2, and 3 I skipped. Like I said, go to the article or go to the website and you can read it. So number 4, there are compelling indications that the causes of the current levels of disruption are unique. According to Excel Bio's analysis, historic causes of disruption that may be ruled out as causes of current disruption include lack of international recognition and experience of Ebola, lack of local recognition and experience of Ebola. So restated another way, the problem today is not that people do not understand that they are facing Ebola, which was a condition that led to maximal sustained disruption in the past. It is Excel Bio's assessment that risk communication and education campaigns that should be driving containment have been ineffective, if not counterproductive. The level of disruption is rooted in locals' rejection of these initiatives associated with international aid workers. These conditions are similar to what caused these conditions are similar to what was observed by Excel Bio after the 2010 Haiti earthquake. It is Excel Bio's assessment that the broad solutions will require a specific focus on fixing communications and trust failures at the local level. Obviously, that's dealing with West Africa. In the Western world, I think it's the exact opposite. People are scared to death of it and will do whatever people say. Number 5, there are indications of drivers for evacuation and flight. This is big. It is important to recognize that evacuation and flight are common, routine components of the Ebola signature pattern. In the case of Sierra Leone and Liberia, non-essential personnel have been evacuated. However, current reporting suggests expatriate healthcare workers will seek to evade airport screening procedures and violate their quarantine contract in an effort to flee the epidemic zones. At the community level, we have indication of non-ambiguous disaster conditions as mentioned above. Excel Bio has received multiple reports of abandonment of the dead in indigenous homes where the inhabitants fled in fear. This implies a potential to reach an extremely rare but known apocalyptic level of disruption referred to as an IDIS Cat 7. This level of disruption refers to a total loss of social control to the point of abandonment of living family members, also known as familial disintegration. This has been observed rarely in history and has been seen with first contact situations with Ebola, Marburg, and Nipah viruses. The importance of this is a community shift from convergence to care for loved ones to divergence away from the ill. The latter point then highlights the threat of future expansion throughout the region. Therefore, we continue to have risk of both terrestrial and air flight-based trans-relocation of the epidemic. You got that? So instead of people staying home to care for the sick, once the person gets sick and they realize what it is, they leave. And when they leave, they could be carrying the virus with them. So it increases the chance of it translocating, as they say. Number 7. Regarding translocation to developed nations such as the United States, Excel Bio does not assess there to be a significant concern in terms of seeing an uncontrolled epidemic. Small case clusters are possible. The key to mitigation of the potential for an IDIS Cat 3 crisis condition is the element of surprise. Local physicians must be sensitized to the possibility of translocation and prepared through education and preparedness training. Particular areas of sensitivity include the emergency department and ICU, which are critical structures that ensure continued ingestion of patients for any developed nation's hospitals. So what we're seeing is when the patients come in, the emergency room and the ICU are being shut down. And that's, obviously not helpful for everyone else that needs that service. So live feedback from one of the nation's largest social networks for physicians, CERMO, has indicated significant anxiety and concern that the medical community is unprepared. So they did a survey of 929 medical professionals, and this is what happened. How prepared do you feel the U.S. healthcare system is to respond to an Ebola outbreak? Very unprepared, 383. Extremely unprepared, 315. Neither unprepared or prepared, 157. Very prepared, 65. Extremely prepared, 9. So let me put those numbers another way. 70% of the people surveyed said we are very unprepared or extremely unprepared. 70%. 16% said, meh, either way. And then the rest said very prepared or extremely prepared. So I guess that would be 14%. So 70% of healthcare workers surveyed, the largest social network for physicians, said we're in trouble. 70%. Keep that in mind. And then here's another first-hand account. So one Excel Bio team member was in the process of prepping to deploy in Samaritan's Purse to support medical response. His observations about federal assistance associated with the potential deployment included the following. Finding a single focal point for credible, vetted information was difficult. He said that's typical for disaster response. There was significant difficulty obtaining the latest guidance for PPEs, clinical management protocols, and specific isolation ward management information. Many subject matter experts in the government had differing views, where disagreements between agencies resulted in lack of clear consensus regarding therapeutics. So it's hard to find what to wear, what to do, and how to care for patients. People also have different opinions on how to treat the patients. The impression is that Cell Bio team members in the U.S. government no longer enjoy the same level of experience in Ebola management it once had in the late 1990s. Protocols were not in place beforehand to assist non-U.S. government American citizens in medical evacuation and aggressive treatment for high-consequence pathogens. Basically, what we know is that it's incompetence. The CDC and all, they're going to put on a strong face that we know what's going on, but behind the scenes, they have no idea. All right, so they're summing it up. Based on the analysis and observations, the following scenario probabilities for the current outbreak have been assigned by Excel Bio's operational biosurveillance SMEs based on the review of available data. So everything that they've done, the 8 points, this is their summary. Scenario 1. Locals will learn and adopt effective containment practices in the next weeks. Right? 80% chance that absent a resolution of ineffective risk communications and education campaign approaches, the level of disruption will remain high and medical countermeasures will continue to be suboptimal. 20% chance that fatality numbers alone will create conditions where locals generate independent reasons to apply the same containment methods being promoted by the international health authorities they are currently rejecting. So there's a 20% chance that because there's so many dead people that they're going to have no choice but to listen to what they're currently saying is BS. 80% chance that regardless, nothing's going to change. Scenario 2. Locals will learn and adopt effective containment practices in the next weeks through a resolution of current trust issues. 40% chance that through concerted efforts to better engage directly with local community leaders, trust will be built to enable effective containment practices. 60% chance locals will remain hardened against international health workers in the weeks ahead. Not very promising. And this is the last one, so thanks for staying with me if you're still here. Based on this most recent analysis, Excel Bio concludes that high fatality numbers, spread, and continued hardening against international health workers, coupled with a strained medical infrastructure from international to local capabilities across multiple urban areas with international points of entry, would create conditions suitable to more translocation and threaten far higher fatalities. There's nothing good in that sentence. To further illustrate the potential risks associated with this current outbreak, public health experts have expressed concern about scenarios that may present direct threats to the continental U.S. One current example of a continental U.S. safety concern involves expatriate healthcare provider elopement from quarantine. We've seen that. 12 of the 49 U.S. expatriate healthcare workers healthcare providers working in West Africa supporting the international medical response to the current outbreak have violated the terms of their quarantine contract and are returning prematurely to the U.S. 12 of the 49 are getting out of Dodge regardless of the quarantine, and they're just coming back because that's how bad it is. Ugh. So go check out the whole article. There's more, but I didn't want this to be a 40-minute video. So, like I said, very in-depth, great information in here. All right.